We now come to the endowment lecture series at AIOC 2023 Kochi, and it's my privilege to call upon Dr. Samar Basak, Dr. Barun Naik, Dr. G. Nageshwar Rao sir, he's on the stage, Dr. Lalit Verma, Dr. Harvansh Lal, Dr. Arup Chakravarti, Dr. Chitra Ramamurthy, Dr. Namrata Sharma, Dr. Santosh Honawar, Dr. Somashila Murthy. So, welcome to the endowment lecture series, and we have the Dr. Daljit Singh endowment lecture, which is to be delivered by Dr. Devashish Bhattacharya sir.
Good afternoon, everybody. It's been a great honor to have the Dr. Daljit Singh endowment lecture conferred to me by the scientific committee, and I wholeheartedly be humbled and thank the scientific committee for the same. The topic given to me is the science of ophthalmology and my philosophy. This was a bit confusing to me because I really didn't know what's expected out of me. Maybe what I could read is to read into the ophthalmology 10 years from now, what it could be probably, and give my perceptions around that. So I'll stick on to that. But before I go, well, a word or two about the most illustrious person, Dr. Daljit Singh, who introduced or did the first IOLs as an Indian in 1976. He was a Padma Shri awardee and a Dr. B.C. Rai awardee too, but a very plain-spoken person, straight and from his heart, and all that he had in his mind was the benefit and the goodness of science that could be translated to his patients. He also invented the Fugo knife, and I remember, in those days, 85s, 90s, he would carry up in his pocket the steel sutures and the 30 gauge needle which he would to cut and have an eye in it, and would hand over to me, use this. And he used to really push us. And those days, 80 braided silk was the suture. The patient would not be very comfortable with those sutures, but these stainless steel sutures that he invented were amazing. And of course, he was the popularized the John Wurst Irish claw lenses. And I remember in 85 when I first saw an IOL surgery in Chennai, AIOS, he operated. He said, I'll operate with my loop, and the assistant holds it, and it's very coaxial, so that's very good for my surgery. And you can see with the microscope and the CCTV and all that. So those were the learning days, and I really want to go back to those days when I met a friend and I said, hello, yaar, how do you do? And he said, I do both, anterior and posterior. I said, what is that? But no, I do anterior chamber lenses and posterior chamber lenses. So, those were times when we kept on learning. I see all the young faces. This is the way it used to be, Keiki coming at 7 o'clock in the morning, giving breakfast lectures, and maybe at 7 in the evening, Dr. Chandan Abrams talking about green lasers. So much happening, so much learning. Now things have slowed down and graduated to big machines, but these were very individual, practical tips handed over by people like them. And here you see his two sons, Kiranjit and Ravijit, and daughter-in-laws, the entire Daljit Singh Eye Hospital pilgrimage for all of us. And this was his Irish claw lenses. He's implanted more than 150,000, which includes also the president of our country, Mr. Jail Singh. And strikingly similar, when you go through Sir Harold Ridley's life, you find the same, connotation. Great surgeons, great innovators, used to do things which others couldn't, and others would have complications. And so their invention was in a lot of turmoil, because they were probably said, why did you at all put a foreign body in the eye? There were times in those periods where surgeons used to say there are two kinds of IOL surgeons, one who put them in and one who bring them out. And I'm very proud to be of the second order. So all these things they had to fight through, and this took them, and the thing that really helped them was their absolute non-financial approach to the whole thing. They did it because they thought it was right for their patients. And the Rayner lens, the first Rayner lens just costed £1. And just imagine if that was to be done today, what would be the cost of an intraocular lens with these patents and everything? Would the third world get it? Would we be, or Indian ophthalmology be as it is today? So we owe all this to these great people. Partho, is it a 15-minute lecture or 10-minute?
Sir, 10.
10 is it? I'm sorry. Okay, so
continue,
essentially...
Sir. Can continue, sir.
Sorry?
You can continue, sir.
Okay. The Indian ophthalmic scenario is quite, clean cut with this welfare, because we do need welfare in one segment, where the NGOs, institutions, we have very specific institutions like LV Prasad, and the government institutions, whereas they also, and the private practices, strive to hit sustainable affordability by a participative approach from the community, where they do good to the patients, earn from the patients, plow the surplus, and build up practices. And of course, now there is an aspirational and a promotional segment where private hospital chains are promoting, trying to do more by even diluting their equity and getting into the, trying to provoke aspirations. Well, simply, I belong to the health is definitely going to be the next geopolitical agenda, no doubt about it. You see all political systems, and they have, they always talk about health. And obviously, as I said, these are the three main modalities in which healthcare, eye care is being distributed. Well, the affordable, sustainable, equitable model is perhaps the one that strikes everybody. And in these era of patient experience, we often ask one little wrong question: what does the patient want, so that we can give him. But perhaps a good beginning point would be to say they want everything. So essentially, it would be better to find out that what is the patient willing to pay for, because what we can afford could be the starting point, of course keeping stringent quality standards in mind. And obviously, if we keep cost before quality and cost together, then obviously at some time quality improves cost further, and simplification is actually the ultimate sophistication and the way to go forward towards affordable aspirations. It is India's decade, 5 trillion economy. Well, that is very enlightening, and a lot of ophthalmology to come. So it is also, this is a chart where it shows how our hospitals, 1 lakh surgeries, what is the average ticket size per patient, and the GDP of West Bengal. So as the GDP is gone, it is 1.5 times the per capita per month income of a person which he can affordably spend for visual rehabilitation from with cataract surgery. Now, if we see India, the red spot is a clear outlier in the entire map. USA, which has almost 20 times higher GDP than India, is only twice in terms of the cataract surgical rate. So essentially, from these great people and the great institutions that have been nurtured in India, our penetration into the community is excellent, and therefore, if India does well financially, we will definitely do very well. The GDP is going to double in 10 years. That's what the projection is. And the demographic dividends is, the India's really grown between 1980 and 1990. That's the time India has really grown. So naturally, the elderly population is not going to come down anytime soon. And of course, things are going to get hyper local. So we have to get prepared with some things, especially with the industry. Now you have an OCT, and the OCT can give you everything. Anterior topo, posterior topo, corneal thickness, angle, RFNL, macula, biometry. But why there are 3 machines for that? So this one machine can actually go around, and we can plan even home care. It doesn't need a technician, it doesn't need a doctor. Suppose we diagnose a diabetic retinopathy and we convince the patient that you need, it's 20 years of since you are diabetic, you have comorbidity as hypertension, so you need to be scanned with OCT every year. Our person will scan you out, and if it is good, you are fine. If your vision is 6/6, you are fine. Need not consult a doctor. So, these are many things of the few that even home care can be possible. Swiggy, Zomatos have shown us how supply chain and logistics can work down the line. Similarly, to see, microscopes and lenses can't get any better, but the chips and the televisions or the OLED, QLED, everything is going to get better and better. So I think this is the way forwards to see the eye. And obviously we can have these teleconsultations with OCT as one of the main pillars to the whole game. And obviously you see how the vision at operation is going down by time, and we are operating more and more of 6/6 eyes. And I think some of the people sitting down in the back bench cannot read the last 2 lines, but it should be read. So, that is definitely true, that the Snellen's chart probably will be replaced by contrast sensitivity. And we will be saying that to improve your contrast, you're 55-year-old, your accommodation is no more active, we can replace your lens. So these are errors and exciting times, and we are going to do 3 to 4 times more cataract surgeries, and obviously early lens exchanges will reduce glaucoma. Injections are going to go enormously high. Actually, the Western world gives almost the same number of injections as cataract surgery, but we do 70 lakh cataract surgeries but give only 4 lakh injections. I think there's a long way to go, and once we do that, there won't be any bleeding, vasculopathies. The drop nucleuses are gone, infective endophthalmitis coming down. So what remains for the VR surgeon? Only maybe interface disorders, which will constitute the bulk of vitreoretinal surgeries, and add on telescopic lenses, field magnifying IOLs, very exciting world ahead, artificial corneas. And I asked AI to do this little thing for me, that in all this AI and everything and what's coming, I feel that, are we getting squeezed into machines? But honestly, see this beautiful picture, it did it to me in 1 minute. And this is not what we should be looking for. We shouldn't be squeezed into machines. Machines are for us, for human beings. And let us do good to humanity, do good to human beings, and live a good life. Thank you very much.
Thank you very much, sir, for your lecture, and we are privileged to have you as an endowment lecturer for our legendary personality of Indian ophthalmology, Dr. Daljit Singh. Next, we would invite Dr. L.P. Agarwal, lecturer, Dr. G. Chandrasekhar, for the talk. Dr. L.P. Agarwal, Dr. Lalit Prakash Agarwal drafted the National Program for Prevention of Visual Impairment and Control of Blindness, now called the National Program for Control of Blindness in India, in 1976, the first of its kind in the world. With his vision well ahead of his time, he brought the concept of super specialty in Indian ophthalmology. He founded Dr. Rajendra Prasad Center for Ophthalmic Sciences, the apex government ophthalmological center of India. His contributions to modern Indian ophthalmology were so profound that we may not be mistaken by calling him father of modern Indian ophthalmology. Dr. Agarwal's death was a tremendous loss to Indian and global ophthalmology. However, he remains immortal through his time-changing concepts, blindness control programs. To deliver this lecture, we have Dr. G. Chandrasekhar, Vice Chair Emeritus, L.V. Prasad Eye Institute, Hyderabad. Welcome, sir.
Thank you. At the outset, I would like to thank the All India Ophthalmic Society, the scientific committee, for giving me this privilege of the L.P. Agarwal Endowment Lecture. I'm truly honored. I had the fortune of actually seeing L.P. Agarwal in action. If we have all the subspecialties in ophthalmology that are thriving now, it is only because of him, his vision, that he created the subspecialties in RP Center during those days. His vision for future was immense, and he never did anything that he did not expect others to do. Just to quote, those days journal clubs used to be the complete journal, not just the selected articles. And if I was presenting, if he wanted me to skip article number 5 to 8, he would summarize those articles before he asked me to go to article number 9. He's a legend. The topic seems to be common for everybody. That there is an enormous scientific progress is undisputed. I trained as an intercapsular cataract surgeon. We only had enucleation and deep DXRT for retinoblastomas. Now we are talking about saving vision and saving life. Vitreous surgery was not known, it was only scleral buckling, and we have 26 gauge, 30 gauge vitrectomies. So the quality of life improvement and the ability to retain, recover vision is excellent as far as science is concerned. But I want to flip the coin and ask the question, what's the cost of this progress? Are we losing the patient for the eye and for our specialty? What is the healthcare milieu, and what are the influences of conflicts of interest? This point is brought out very nicely by in the Vandal Hughes lecture by Jeff Nerad. He says, during the first half of my career, I was passionately consumed by every technical detail of our trade, loving to learn more advanced and complicated procedures. At his age, what he says now is that I was missing something very important in my role as a physician, being there for my patients both as a doctor and a human being. It seems to me that only through experience, underlying mentorship from others, can we learn the importance of caring for our patients. Fortunately for me, I trained with Dr. N. Sood and was inculcated into humanism and patient-centric care, the terms that I did not know at that time. And I continue to be lucky working in LV Prasad Institute under the leadership of Dr. Rao, who brought in the value of patient first and said that growth without compromising standards and sustainability without neglecting the most neglected should be the vision for the institute. Thank you, Dr. Rao. We all want to be a good super specialist, and in the bargain probably forget being a good human being first, then a good doctor, ultimately then a good ophthalmologist, and finally a super specialist. So my philosophy is talking about winning the patient trust by medical mindfulness. What is medical mindfulness? One should become master of one's mind rather than let one's mind master him. If that sounds esoteric, the ability to reflect on one's thinking while acting distinguishes the truly outstanding professionals. Can we try to get there? Thinking about thinking is metacognition, and that is what I think we need to be doing as medical professionals when we take care of our patients. Extensive books are there on this topic, but I will try to connect the dots between what these books say and what would we need doing with patient care. We cannot win the patient trust if our diagnosis is wrong and if our management plan is not patient-centric and responsible for what the patient can afford. So the loopholes for a good diagnosis I will address are biases in making a diagnosis and the term called hyposkelia. While we make our management decisions, we need to fight against the therapeutic illusion and the illusion of control that we have, and we need to develop empathy and a good level of communication with the patient. These are what is required to be able to reflect on while we are taking care of our patients. So talking about biases first, this book has taught me all the biases. I knew only hope bias and expectation bias. Just to get the last two out of the discussion first, I have taken care of a patient excellent, 6'6" vision. He keeps coming into my clinic and keeps complaining of this irritation there, that irritation there, and things like that. I attribute to him that he wastes my patient, my chair time, and if he comes with a subtle venous occlusion, we are likely to miss him. I am taking care of my friend's father. I don't want him to have any disease. I might under-investigate him, not do a gonioscopy, and misses something that is important. So these two biases are something that we need to remember. The hope bias and expectation bias can simply be explained by the fact that if I have done a trabeculectomy, if the pressure is 19 or 20, I am likely to record 18 or 19. That's my expectation. If I am diagnosing a glaucoma suspect, the same 18 or 19 are likely to be recorded 20 or 21 because, sorry, the other way around. The hope bias for the trabeculectomy and the expectation bias for the diagnosis of glaucoma suspect. The antidote for that probably is going to be null hypothesis that I'll explain. Confirmation bias and search satisfaction are the other biases, and there is an approach that we can go for that called the 3D approach. Is it 15 minutes, I believe, right? Okay. So when we look for a clinical finding, this is about the null hypothesis, or evaluate a diagnostic test, can we seek evidence that is contrary to our favorite hypothesis? That is what is null hypothesis in clinical medicine. Carefully looking for what else is there before I say that this patient needs cataract surgery and not miss a macular hole. So this patient was being treated for recurrent HSV keratitis for about 5 years in LV Prasad Institute, and it required somebody like Praveen Krishna to start asking the question what else is there and why is he not responding, and think about his thought process. That led him to look at this full thickness scar, and that full thickness scar led him to actually look for a foreign body in the anterior chamber, by which time the cornea had decompensated and he had to do a dissect and remove the foreign body. So that's the null hypothesis. You don't get carried away by your favorite hypothesis. Moving on, what was happening with all the other ophthalmologists who were taking care of this patient over 5 years was diagnostic momentum. Somebody diagnosed HSV keratitis, I will change the treatment, increase the steroids or add one more antiviral. That's the confirmation bias is basically same as that. So the antidote to this is given by this thesis from Boston University, where 46 anesthesia residents were put to the exercise of taking care of a mannequin undergoing appendectomy, 26-year-old lady with bronchial asthma. Before the surgery starts, there is hypoxia. So the exercise for them was to find out the cause for hypoxia and treat it. It turns out that only 7 of them managed to survive the patient. In all the other hands, the patient died, mannequin died. And the thought process that they went through was analyzed, and they were divided into 4 categories. The first category is stalled. All of us, when we had our first nucleus drop, our mind stops working. We just don't know what to do next. The second is fixated. You think of only one diagnosis like the recurrent HSV keratitis and not change the diagnosis, keep on changing the treatment. The third one is a diagnostic vagabond. Start antiviral one day for an infective keratitis, next week antifungal, third week antibiotic, fourth week steroid. So we are a diagnostic vagabond and not nailing each diagnosis completely. The 7 successful people actually were adaptive. They thought of more diagnosis and took each diagnosis its logical conclusion. That's why they were successful. So what is the approach? It's called 3D approach. Am I gathering all the data that the patient is giving before I'm making my differential diagnosis? How many differential diagnoses am I considering, and am I taking each one to the logical conclusion? That's the 3D approach, and this is once again ability to reflect on one's thinking while one is in front of the patient. Briefly about hyposcilia, which can also be called tyranny of technology. It's a beautiful article by a cardiac surgeon from Texas. While modern medical technology greatly enhanced our ability to diagnose and treat disease, it has also promoted laziness, especially mental laziness, which prevents us physicians from using the most sophisticated, intricate machine that they will ever and always have, the brain and the eyes. So to drive home the point, let me tell you about this 49-year-old lady who was diagnosed as having angle closure glaucoma, had these visual fields that were very advanced, went on to a second ophthalmologist, the visual fields were same again, and somebody actually added her a CT scan of the brain. So this 49-year-old lady now not only has to deal with her glaucoma but also with a possible brain disease. When she presented to us, her pressures were controlled, her disc showed that in the right eye there is advanced damage, but the left eye was a glaucoma suspect at best. So reassuring the patient and telling her that you are not going to go blind, and put the patient in front of the machine, and also requesting the technician to be a little more soft to the patient, actually shows that the right eye disease is not that advanced and the left eye is almost normal. So the same article goes on to say, I fervently hope that the current teachers of medicine can somehow recapture the Oslerian spirit and strive diligently to restore the very core of doctoring, humanism. Teachers who understand and believe that medicine is a calling and not a business is what he asks for. Talking about therapeutic illusion and illusion of control, there is a lot that is written that we unnecessarily do procedures that probably are not necessary. Unfortunately, the thought process turns out to be all interventions that are potentially beneficial are justified. Intervention is justified if it is unlikely to cause harm. Clear cataract extractions for angle closure disease, angle closure suspect. Expensive and non-validated diagnostic and therapeutic interventions are being used right and left. Talking about empathy and communication, this article beautifully talks about the gap between the evidence-based medicine that we practice and the patient-centered care. The dialogue that we have with the patient can be in 2 sides. 1, who controls the dialogue, and 2, what is the content. Whether we are dominating or whether we are able to listen to the patient's problems. The content could be totally biomedical or biopsychosocial. What is biomedical? As a doctor, I am interested in what is the chief complaint, what are the details of the course over a period of time, what interventions and what outcomes have already been done, what is the patient's knowledge about the diagnosis and prognosis. But from the patient's perspective, what is the cost of therapy, what's the duration of recovery, what are going to be the residual effects and complications, can I sustain my livelihood subsequently, and what are the aspirations for future. So these are the things that we probably do not control. But if there are 2 options that are available, if we factor in some of these, can we actually be more patient-centric and empathetic to the patient? The contribution of the doctor is threefold in practicing evidence-based medicine: evaluating the research evidence, exploring the patient's philosophy of health, and delivering an opinion based on a synthesis of those 2. We need to remember that in this complex milieu of academia, industry, and physician, everybody claiming to be patient-centric and interested in the patient the most, the patient is the one who does not have any voice. And we need to be careful about that. So I talked about the biases and skill and hyposcilia and the therapeutic illusion and the empathy and communication. If you want to win the patient trust, I think what we need is the ability to reflect on our thinking while we are dealing with the patient. I once again take the opportunity to thank my mentors and the prayer in conclusion. From inability to live well alone, too much zeal for what is new and contempt for what is old, putting knowledge before wisdom, science before art, cleverness before common sense. From treating patients as cases and from making cure of a disease more grievous than its endurance. Good Lord, deliver us. Thank you.
Very much, sir, for your lecture. We are obliged to have you here. And now we go on to the next lecture, and that is the Dr. P Narumal Swami lecture. And Dr. P Narumal Swami is one of the founding members of the Aravind Eye Care System and is currently its chairman emeritus and professor of ophthalmology. Dr. P Narumal Swami started his career at Government Rajaji Hospital, Madurai. He established India's low vision aid clinic in the year 1967. After training in the USA, he started Vitreous Surgery Center at the Government Rajaji Hospital, Madurai, first of its kind in India, and then Retina Vitreous Clinic at Aravind Eye Hospital in 1979. Dr. Narumal Swami established the Center of Relevance and Excellence in Diabetic Retinopathy in association with Government of India, World Diabetes Foundation, Denmark, and with Topcon. We have great pleasure in inviting Dr. Madhu Bhaduria, Director, Regional Institute of Ophthalmology, Eye Hospital, Sitapur, to present the Narumal Swami Endowment Lecture.
So at the outset, Dr. Rao, the dignitaries on dais, and everybody in the hall who's my colleagues, a very good afternoon.
Yeah.
And topic is same as Dr. GC said, topic is same for everybody, but maybe the world we look at through our eyes is different. So Dr. Nam, I'm sure everybody not only knows him, knows about his accolades. But I picked up this from Dr. Das's article in IJO. To find your mission in life is to discover the intersection between your heart's deep gladness and world's deep hunger. And at that moment, Dr. Narumal Swami chose the world's deep hunger. But with the masterly art of practicing science, he wove what he wanted to do in the system, and today where Arvind stands, it stands. And these are the pictures of him and his family, GN also. So science in ophthalmology from Sushita's time has come today to stand at all the artificial intelligence, stem cells, nanotechnology, molecular biology. And if these are the things we discussed, it's really not time enough, and it's really going to progress. We are still in the imaging and doing things manually, but probably a lot will go forward. So beyond this, I'll talk about the philosophy. Truly, I'm not big enough to have any kind of a philosophy, but all I would say how I perceive it. So I perceive as first the development of thought process in an individual, learning of science in ophthalmology, practice of science, and transformational moments, which are there almost in everybody's life about different things. So I'll take myself as a subject. I was born in a village, but not unwealthy. I was wealthy. But what I got to learn from there was that people were poor and my family was supporting them. So strong community orientation and caring and respecting people. Teenage, I didn't want to do medicine. I did to please my mother. I didn't want to do ophthalmology. I did it just to have a chill time. But then there comes a small transformation. I fell in love with medicine, and there it was. For me, it was a pure science. And I really wanted to go for research and all that, but actually that didn't happen in my life. And only motive probably that time was to do a most ethical and do best for the patient. So Dr. Mehra was a profound teacher, but somewhere down the line, he prepared me. But somewhere I think he went a little wrong somewhere. And till that time, I took everything for granted. So someone dropped in my life, got married to a paratrooper. joined Army Medical Corps. And after that, my life itself became a battlefield. He was on missions. And the profession was a starvation and frustration in Army. Initially, when I joined, was a terrible place to be in. But, this made me realize the value of poverty in profession. And I really learned to value the abundance that I had in past. And then came Dr. Badrinath in my life. So I went to Chennai on transfer, 6 years between MH and Shankar Netralaya. The other things Natti will tell, but I'll tell you what I learned from him was to respect and care for the fellow ophthalmologist. I was really old by the time I went there and not expected to give a fellowship, and he didn't even make a bone about it. He just said, walk in. So that, and during that period, I stayed with him. Somewhere the institution built in, it just got in. An important thing he told me that you don't know how to give up, so probably you're a different material. So how I practiced was, I came back to Army, there was no going back. Army controls your life and you don't control yourself. But I tried, worked hard to get whatever was required and did my best. And I would call that AFMC and Army Hospital RNR my golden time. My areas of interest have been actually valves and imaging, and that is the only area in which whatever little I published or presented. So coming down to a belief system, success is not what I think is. Success is not as a result or achievement. Success lies in intention, endeavor, and putting your character in it. Once all is invested, one is already successful. So we don't need to really search for it. And knowledge is of no value if it's not put into practice. So from AFMC to this is Sitapur was a change in my life. It was very dramatic, traumatic, and very harrowing because where I landed was a really jungle. So this transformation of Sitapur and transformation of two of us, me and my husband went side by side. During doing this, what it was needed, what was not what we liked. It was just about not giving up. And the four things we really took in mind was caring for the community, doing the best for the patient, doing it with integrity and honesty, and develop people and the institution side by side. So with that, it will be unfair not to talk about Dr. Mehra over here. Dr. Mehra was the one who had all these specialties in 50s, right? There was disruption, so multiple things came, but everything of first Zeiss came there, and then he was the man who took all this to these kind of masses. That was phenomenal achievement. I don't think anybody in India has been able to do so much so far. So what happened is the disruption, and the last bottom that you see was the time when we entered in Sitapur Eye Hospital. And the biggest nightmare was to tell your person who was your hero, who prepared you, that all your paradigm was wrong. It's not about the money. It's about the value-based organization, having a proper vision, mission, and a passionate leadership. So that was a nightmare. It needed as much courage as it needed for my husband to chase out the mafia from there. So we started with these 4 parameters, which are used by all not-for-profit hospitals. And HR of Sitapur was the worst possible in this country. And Dr. Badrinath told me, don't go there, the HR is very bad. But whatever it was, it worked. The moment he removed the mafia, the fear of devil was put in and the people changed. And that is the time we realized that trust and honesty were the most important virtues. Whatever we said, we did that. So lost clientele was because of everybody knows a hospital goes down, everybody runs away. And cluster endophthalmitis was the worst. So we really worked. We went lots of interventions. Today we have 19 OT tables in 6 OTs, all the equipment for diagnostics. Medical education, now we have degree instead of diplomas in MS. We have bachelor optometry, diploma of ophthalmic assistants, fellowships, so far only comprehensives. And all kinds of things that LVAs and whatever happens in not-for-profits and other hospitals, we have the full-fledged running system. Surgeries went up like that. COVID disruption came, and this year was better than ever before of Sitapur. So we started also camps, comprehensive camps, pediatric camps. Vision centers, they're very close to my heart, and these are all tele-enabled vision centers. EMR is, as per the hospital, they do screening for all the fundus diseases through eye-like and artificial intelligence integrated device and the human interface. Plus, they do corneal ulcer prevention program. And 7 vision centers are green, which have solar, electronic bikes, and everything of theirs runs on this thing. It's a paper-free office for 7 vision centers. So training of grassroots level workers was another thing we took, and that came because of corneal ulcer prevention program. These girls are trained to sensitize people in the villages about the diseases, and they can give the first aid what is required. So COVID interventions, this is, this one said, Disha said, Dr. Bhattacharya said, so this is the door delivery during COVID. Our motorbike-borne people went to our patients' places and they delivered basic 4 services: vision, refraction, spectacles, medicines, and referral services to hospitals. So when the weather became bad, it became mobile, this thing. And these mobile vans are just like vision centers of ours in the hospital. So finances had to be done from all over the place. So we used all the sources from the government, donations, NGOs, INGOs, optical, medical, catering, etc., etc. And this was not done alone. Our most important and strategic partners plus operational partners now are Arvind from since November 21. And other partners are Sightsavers, CBM, SightLife, Vision Foundation of India, Orbis, Perkins, Jeevdaya Foundation. And these people have helped in multiple ways to bring up to Sitapur where it is today. A program very close to my heart is this. If you treat an abrasion, you will not have an ulcer, no scar, and you will not require keratoplasty. So we started this program with the Sight Life in this thing. The girls were given a toolkit, they were given training, and they were given this app. And this is a 5-year project actually, so 3 years are over. And the results are really gratifying that only 1.2% needed referral and hardly anybody needed a keratoplasty. But the second part of this program is also the follow-up of keratoplasty by the grassroots level, not the grassroots, the first primary means vision centers. This is the Trash to Treasure program. These are Samsung bad phones, AI-enabled devices I like, Bluetooth attached to it. And what we do with this is we are using in 13 vision centers. And these are the 4 diseases we are screening the patients for. Their criteria above 40, anybody comes there is screened for. And we have found sizable number of patients actually requiring treatment. So this is another good thing that we have been able to, like this is how we have been trying to put the science or the thought process, like abrasion treating is a very small thing, but it's just about the thought process. So we are putting whatever we have. And in the end, I would say we shall not be judged by our education or wealth, but how did and how many lives we have impacted. Thank you so much, sir.
Thank you, madam. Thank you very much for your lecture. Now we come to the next lecture, and that is the AIOS SS Badrinath Endowment Lecture. Dr. SS Badrinath Sangamendu Srinivasa Badrinath is Chairman Emeritus of Shankar Nethralaya, Chennai, one of India's largest charitable eye hospitals. In 1978, Dr. Badrinath founded the Medical and Vision Research Foundations in Chennai. Shankar Nethralaya, a charitable not-for-profit eye hospital, is a unit of Medical Research Foundation. Right from its inception in 1978, Shankara Nethralaya has been offering fellowship programs in ophthalmology. The institute also offers training programs for graduates in ophthalmology. Dr. Badrinath has been awarded by the 1996 by Padma Bhushan, 1983 Padma Shri, 1991 Dr. B.C. Roy National Award, 1992 Paul Harris Fellow Award, 2009 V. Krishnamurti Award for Excellence, 2009 the Madras City Ophthalmological Association Lifetime Achievement Award. Today it's our great privilege to have Professor Dr. S. Natarajan, Treasurer, International Council of Ophthalmology and Chief Clinical Services, Aditya Jyot Eye Hospital, present the lecture, the SS Badrinath Endowment Lecture. Please, sir.
At the outset, I would like to thank Partha for giving this opportunity. As Dr. all of us have the same topic, the science of ophthalmology and my philosophy. So I quote William Arthur saying, the mediocre teacher tells, the good teacher explains, the superior teacher demonstrates, and the great teacher inspires. And whatever I am today is because of Dr. Badrinath. And there are my 4 elements. With their blessings, I am a good eye doctor, working with the aim of nothing less than excellence. My parents, Dr. N.S. Sundaram, my mother, Mrs. Kamala Sundaram, my guru, Dr. Badrinath. And from that movie, Rajinikanth's movie, Kushalan, I learned Mata, Pita, Guru, Mitra, and Deva. Mitra is Shivanandan, who's my mirror for my life daily. He will question me every day, whatever I'm doing. I think he rarely appreciates, and finally, God. So we listen to Dr. about Dr. Badrinath. Now, the words of Shankaracharya, the need to create a hospital with a missionary spirit inspired Dr. Badrinath to start a charitable non-profit eye hospital. And this was one of the visits when he came in 2001. And I worked as a consultant earlier than from 84 I was with him, and I think I worked day and night with him. Maybe I'm the only one who could work every day with him, and he inaugurated the hospital along with none other than our Gulabali Nageshwar Rao in 1990.
Chief guests to the function, Dr. Rao, Dr. Natarajan, Dr. Preeti Natarajan, the elite of Bombay. May I first express my respectful greetings to one and all of you who are assembled on this very important and momentous day in my life. I carry with me the greetings of one and all of Shankaracharya, with which Dr. Natarajan was associated for almost 5 years, since 1984 to 1988. We are a family, a close-knit family, only about 300, and Nati, and they call you so publicly. I carry with me the very best wishes of one and all from Madras for you to succeed in your new project and to do service to the mankind in this part of our great country. It's indeed a very proud moment. I began mentioning that this is an important and momentous day in my life. I would like to underscore that, and I know my Nati is inaugurating this Aditya Hospital today. Of course, I'm thrilled, extremely happy, very proud of this occasion of what Nati has been able to achieve.
So you can see young Dr. Gulapalli Rao in the video. So the science of eyes in ophthalmology, I think many people have mentioned various things, and I think the practice of ophthalmology has been documented since ancient time. Its existence can be tracked back to ancient Babylon with a reference to the eyes made in the code of Hammurabi in 2250 BC. If a physician performs eye surgery and saves the eye, he shall receive 10 shekels in money. And this was my first exposure to ophthalmology, because I lived in the government ophthalmic hospital where Dr. Nageshwar also lived with his father, and when Dr. Venkateswamy's time, and my grandfather also lived in the same compound. And later, when I was born in 1957 in Madurai, I came and lived in the government eye hospital quarters from 1957 till 1969. And then later, I used to open and clean my dad's clinic. And as a boy, I never felt anything ashamed of doing this simple job. I used to put drops. Sometimes the patient will give some tips, and I never took it. No wonder it has been said, learn to be with the wise and your life will flow and glow. And then thanks to my father and grandfather, I met all the ophthalmologists. So I had a curiosity to use the direct ophthalmoscope when I was a school kid. I used to catch the dog and check the retina. My first time I saw the retina was a glittering retina. I could, with a great difficulty, focus and see. I still cannot forget the dog's retina. So from that, we have come to 3D vitreoretinal surgery. I'm glad one of the pioneers to use 3D, and I do only 3D vitreoretinal surgery. And whether it's a scleral buckling or a vitreoretinal surgery, I do that. So the idea is, whatever you do, everybody can see. And the days when we were assisting in 1994, only the one assistant could see, and that too, sometimes it's like a small hole, and through the contact lens only a 30-degree. And many times, because of the corneal edema, the surgery used to go on and we can't see the retina at all clearly. But from that time, we have come to now. Also, I remember when Gulapalli Rao inaugurated the Aditya Jyoti Hospital, he used to tell, you guys carry the visual acuity chart in the hand. And now I think we can proudly say we do vitreoretinal surgery and get 6, and 5 and better quality of vision. So my philosophy, so you are the king of your own destiny. So I am very proud of my parents. Who this is the government hospital quarters where when I was probably a year old, and I always bow down to my guru. and every day I pray and start my day. This is from my school days, and I actually decided to be an ophthalmologist when I was 5 years old, and somehow I wear tie right from my the school and medical college, and as well as in Shankaranathalaya. I was a captain of our football team in the Madras Medical College, and I was also athletic team, and I was a 10-kilometer champion. And this was the one we did with at that time late Dr. Lalita Kameshwaran, the first vice chancellor. We did the athletic team with the Olympic torch. So even now I go to the gym daily, Monday to Friday and Saturday to Sunday. It's not for boasting, and I want every young person to be fit. The reason is ophthalmologic surgeons have almost 55% have back problem, either a spine or a cervical spine, lumbar or cervical spine. So best is to do exercise. So my philosophy is the 7 secrets of success. Do you find yourself struggling to get things right in your life? A spiritualist offers some simple and time-tested solutions to overcome obstacles and reach for your goals. Every great achiever knows how he arrived at success. The journey has been long and arduous at times, smooth sailing at others, but it has always been something that he or she deeply desires. Vision, a guiding vision, a great dream, and a sense of focus gives one a goal and direction. When, as an ophthalmologist, if you don't, Helen Keller said, no point, anybody's not called a blind. Only people who don't have vision for their life is called blind. Remember that even the most powerful missile is useless without a capable guidance system in control. So learn to have vision. Second is passion. The ability to carry out new plans requires to kindle passion from within. Passion gives you the energy and the reason to weather the storms. And the courage. Life expands or contracts in proportion to one's courage, willingness to take risks, and acceptance to new challenges. Character. Character creates integrity and is the basis of trust. Character is what endues you through your journey till you reach your destination. Character is the world sees, the inner struggles remain hidden. Self-belief, I can. With this in the arsenal and the right attitude, hardships and problems can be overcome. And competence, good is not enough. Strive to be the best in your chosen field, and competence is the difference between mediocrity and excellence. And the Three Idiots movie Amir Khan brings out, if you follow excellence, automatically success follows. Discipline. Discipline means persistence and perseverance, the ability to continue through bad times, obstacles, and problems. And I believe in 6 P's. The 5 P's I borrowed from Shamak Davar, the perseverance, the dance king, perfection, patience, prayer, precision, and precision as a vitreoretinal surgeon I added, and persistence. And when it comes to mastering a skill, time is the magic ingredient. The difference between those who succeed and those who don't is not simply a matter of determination, but more of trust and faith. And I recommend to read this book, Robert Greene, The Concise Mastery. And as a president of All India Ophthalmic Society, I'm glad I induced this screening through teleophthalmology to prevent diabetic blindness, called the Stop Blindness Program, Jot Se Jot Jalao. And the idea was to use low-cost screening devices at primary eye care centers and physician clinics to diagnose diabetic retinopathy. We have various vision centers in various parts of Mumbai in the slums, and this is our social workers go door to door. We have visited more than 2.7 lakh slum houses. We do the PP sugar as well as the HB1AC, and we record their diabetic status and also the BMI, etc. And in ophthalmic trauma surgery, my philosophy is eyes with no perception of light should also undergo a primary repair, even when the anatomical success is estimated to be less than 1%. The idea is not to inoculate or eviscerate. First you save the eyeball and then the vision. And that's what was the Kashmir story. So where whatever the others said cannot be done, I said every patient should be attempted, whatever the vision they can get. In the surgery which we published, 80% have only counting finger, but at least they have one eye with a counting finger and the other eye 6/5. So power of thoughts is more important for me, and that's what I learned from my elders. The Yad Bhavam Tad Bhavati. You become what you think. So I dreamt of to become a best ophthalmologist, and I think you can do that. And positive thinking, the smiling and standing tall emphasizes positive thoughts you have. It will reduce stress and improve self-esteem. and the problems of life are not really out there, they are in here. And so everything is decided in and by the mind. And I think every day the constant question is, how do you grow young? And I think it's all in the mind. The best finding of our generation is that the human beings can alter their lives by altering their thoughts of the brain. Ralph Waldo Emerson declared, "A man is what he imagines of all the day long." And this is what I keep doing. I want to look young, and I color my hair. There's no problem in confessing that. And it's the power of this positive by the fictitious author in the movie. The founder, Dr. Clarence Floyd Nelson. So this is again Dr. Ferenc Kuhn wrote this article. The whole idea is the surgeon dealing with mass casualties must perform as many operations a day as possible, but should also be aware that the heroic's quantity is no substitute for quality. The surgeon's attention span cannot decline toward the end of the day. The last patient must receive the same treatment excellence as the first one did. And this is what I learned from Dr. Badrinath. We used to reach the hospital by 7, work till night 1, and again come back at 7. And I think one day we started surgery at 8 and finished at 4 in the morning. And the next day at 7:45, Dr. Badrinath was there for dressing, and I came at 8. He just looked at me. So I think we have to learn the qualities of a good surgeon. That's again Dr. Peter Wiedemann, the former president of International Council of Ophthalmology, has written how to become a good surgeon. Understanding and treating surgical conditions will benefit surgeons, their patients, and new generations of ophthalmologists, even as robots take over certain interventions. The right mindset and skills are necessary to become a competent surgeon. An excellent surgical mentee needs physics. That's why I mentioned about the exercise for extended operations and for work night hours, passion for learning and helping patient, perseverance, patience, and psych to endure failures. Participation in being a valuable part of the surgical team, planning and portioning of surgical procedures, practice and precision until perfection is close. And that's what Malcolm Gladwell said. You have to work 10,000 hours, and I'm glad I worked more than 20 to 30,000 hours in the vitreous surgery. Sometimes you need a prayer, and that's what he mentioned my name there. A master surgeon possesses expertise, is observant of outcomes, is innovative in treatment, can identify complex clinical problems, ask important questions to improve care, disseminates knowledge and expertise, and trains future surgeons. Creativity exists as one of the most important human resources. It permits us to look past what exists and discover the new ways of thinking. Oftentimes, the limit of knowledge is nothing more than our collective inability to observe the world and ideas in a new way. Albert Einstein, for example, needed to see beyond the Newtonian understanding of the universe to rewrite the concepts of physics. Nobel laureates frequently display enormous amounts of creativity and open-mindedness. Persistence, years of dedication, work with passion, and even when failures are stepping stones, usually predict success. Only those with enormous amounts of persistence can work past these obstacles. From Daniel Kahneman to Malala Yousafzai, Nobel laureates persist when others give up. And the backgrounds of most laureates in medicine are multidisciplinary. Medical breakthroughs, innovations display a rigorous multidisciplinary trend. The unique characteristics indicate the importance of multidisciplinary education in medicine, and that's what I'm learning more about all the Nobel laureates. Again, Martin Luther King mentioned about the Nobel laureate. The recipient needs to have vision in order to drive their project forward for the right reason. The Nobel laureate needs to be able to envision not only how the world will benefit from the project for years to come. And I'm quoting my friend Thirukural, which actually says, "Who knows what's human life befitting grace? He lives, the rest amongst dead men have their place." And he runs the Roti Bank, and I'm a trustee along with him. And he's my best friend who guides me daily, and that's why I wear that badge. We serve 12,000 meals a day free for all the poor people in Mumbai with the hunger map going on. And let man relieve the wasting hunger, men endure for treasure gain, thus finds he treasure house secure. And Swami Vivekananda says, "They alone live who live for others, and rest are equivalent to a dead corpse walking." And nothing in the world can take the place of persistence. Talent will not. Nothing is more common than unsuccessful men with talent. Genius will not. Unrewarded genius is almost a proverb. education will not. The world is full of educated derelicts. Persistence and determination alone are omnipotent. The slogan, press on, has solved and will always solve the problems of the human race. To have an extraordinary quality of life, you need two skills. The first one is the science of achievement, the ability to take anything you envision and make it real, achieve with humility, the power to have anything you desire. From the place which you see on your left is the place where I started in 3 flats and then to the modern building in this. So this is in 1990 to dream it and be it. And the second one is the loving art of fulfillment, contentment. This allows you to enjoy every moment of it. And this is what I do in the day-to-day doing all. And all of us have only one life and only one chance to live it. So live the life to its fullest. So enjoy dancing. And a constant inspiration for me is Swami Vivekananda. Stand up, be bold, be strong, take the whole responsibility on your own shoulders and know that you are the creator of your own destiny. So Dr. Badrinath said 99%. I call it work with passion and 1% inspiration. I thank my colleagues for preparing this. Thank you very much.
Thank you very much, sir, for your lecture. We come to the next lecture of the series, and this is the AIOS Gulapalli Rao Endowment Lecture. Extremely grateful to Dr. Gulapalli Rao, sir, for being present in person in this very important session of AIOS 2023 Kochi. Dr. Gulapalli Rao, Gulapalli Nageshwara Rao, is the founder of the L.V. Prasad Eye Institute, Hyderabad, a former associate professor in University of Rochester. Dr. Rao is a fellow of the National Academy of Medical Sciences, India. He was honored by the Government of India in 2002 with the Indian Civilian Award, Padma Shri. He was elected in 2017 to Ophthalmology Hall of Fame, instituted by the American Society of Cataract and Refractive Surgery. 2012, Padma Shri, 2017. And his pyramidal model of eye health care is his unique contribution for all ophthalmology and has been adopted globally. Today, to present the AIOS Gulapalli Rao Endowment Lecture, Dr. Virendra Singh Sangwan, the Director Innovations, Dr. Shroff's Charity Eye Hospital, Delhi. We welcome you, sir.
Thank you. Thank you, Partho. Can you hear me? I would like to thank the Scientific Committee of AIOS for giving me this such a profound honor of presenting the award in my teacher's name. I am going to talk about, my science, my philosophy and science of ophthalmology will be reflected in the story I share, and that's a reflection of the training that I have received, the space and the opportunity I had while working at L.V. Prasad Eye Institute. I feel that these 3 experiences have had profound influence on me. My fellowship with Dr. Rao in 1992-93, that basically restored the faith that if you are honest and hardworking, you don't need to be known to someone, you can be trained to be a good surgeon. In Orbis International, I learned that ophthalmology in India, in fact, is not very bad when I saw the rest of the world. And the fellowship at Mass Eye India in 96 to 98 shown me that if you understand the molecular basis, you can be very bold in treating your patients. Can we have the audio, please?
Hi, I am Mayank and I am from Ranchi. I had a specific problem in my eye. My day-to-day activities were getting disturbed. Before coming here, I visited Chennai, Bangalore, Kolkata, Delhi, Mumbai, and a couple more places, all of them being topmost eye hospitals all over India. But they all did my procedure, and they all went through certain checks, and no one could actually find a solution to it. Dr. Ashok Agarwal then referred me to LV Prasad Eye Institute. I came here in November 2016. My experience has been just life-changing, and it's been very good.
So Mayank had a eye problem which was diagnosed as dry eye at many places for last 10 years. So here he came with a referral that the boy is feeling depressed, and because he's not able to see light and all that. So when I examined him, I did not find that he has a dry eye, or in fact he has any eye problem. And it was very difficult for him and the parents to understand that this is not an eye problem what we are dealing. And then we started talking about what is that we are dealing with. Then I gave them different suggestions that maybe we should look at consulting a psychologist or a psychiatrist. And it turns out that he had consulted a very good psychiatrist, and he was on a medical treatment which is making a tremendous difference. Very happy with his current treatment, and I wish him all the best.
I was worried about this for the past 10 years of my life, and had I not been here, I don't know how would my future be. I'm so lucky to have you as my mentor, sir.
After 1 month, Mayank's mom just said one thing, that thank you, Dr. Sangwan, for giving back to my son. So sometimes we should know what we are dealing with. This gentleman had an accident when he went to pick up his son. He was doing MSc chemistry and burnt his face badly. The left eye was auto-eviscerated. The right eye had some potential. And after a series of surgeries, reconstructive surgeries, and donated tissue from 2 of his son, we could restore a vision of 20/106, and that served him for quite some time. This is a patient from Stephen Johnson from Zimbabwe. I'll not go through the entire video because of the limited time. Essentially, she recovered her vision after mucous membrane grafting, cataract surgery, and variety of other procedures. But when I joined LVP in 1998, there were 6 cornea specialists, and many of them asked me what I will do in LVP. We are 6 already, and you may not have enough work. Then I told them, please send me cases which you don't want to see, or you think that nothing can be done. So my story, I am going to talk to you about sharing and managing those cases. So SJS is the acute, the most difficult form of eye problem. And if you see the natural history, if you don't do the intervention, they end up blind sooner or later. We started doing mucous membrane grafting, and in this lady, you see the right eye, we did the mucous membrane grafting, and over a period of time, that eye improved, but the other eye started deteriorating, and they become the same because she didn't want the second surgery. We also started doing variety of other procedures for the SJS patients, and patients like this who have bone dry eye, we were fortunate to learn MOOK from Geeta and Vinay Pillai, and able to restore vision in some of these patients. But MOOKP does not work in eyes like this, in a pediatric SJS and a bone dry eye. So we develop a technique called LVP Pro. The LVP Pro technique and the procedure and the outcome is well published in the literature. Therefore, I will not go into the surgical details. And this is the comparison of outcome of LVP Pro with the MOOKP, and we found that the outcome of cosmetic outcome and visual outcome are both very comparable, and in fact, cosmetic outcomes are better. And we were very fortunate to acquire an endoscopic VR system in LVP very early on, and that's where the vision of a teacher or a leader comes into play, that Dr. Rao immediately invested in this technology in 2007 to 2008, 2009, and we started managing these K-Pros and these end-stage eyes much better. Do we have best management of SJS now after 20 years? Maybe not, but we are definitely better off than what we started. We had demonstrated that cataract surgery is safe in a very large series published in 2016. And now we have a good algorithm of management of these patients, and I think there's still more to be done in these eyes, especially end-stage conditions. Then VKC in pediatric LSCD in VKC is another problem which we started diagnosing very early, and this is a short video of a patient whom we treated in 2001 by doing the limbal allo cultivated stem cell transplant, and his graft after 23 years still working and has a good life. All this work led to establishment of a world-class lab at LVP, which was inaugurated by former president and late Sri APJ Abdul Kalam. And then we had variety of other procedures developed, including SLET, which has become now a standard of care for the treatment of LSCD. And this is a patient with 3-year follow-up, and this is a patient, same patient after 12-year follow-up. And this procedure now, if you look at the published literature in last 10 years, 138 publications, and the penetration is growing. It's 1/10 the cost of the competing treatment, which is a clet-based holoclar, which costs about 85,000 to 100,000 euro per patient. We also have been working from 2006, 2007 onwards about developing a bioengineered biosynthetic cornea, and this is one of such an effort. We started in LVP very early, and around 2009 we had done starting these kind of procedures, and this is a patient done in 2016, a recombinant human collagen cornea, and which has been doing well. Subsequently, we published these as a part of the multicentral trial. In the process, we had some patents, and then the liquid cornea work, which started with the Pandorum technologies in LVP in 2014, and that work continues in different forms. And this work continues at Sarof now and Dabur Research Foundation. We have demonstrated that the bioengineered liquid cornea material is compatible, and we have done the histology and although confocal microscopy. So we have been able to establish the lab, stem cell lab, and a liquid cornea lab at Sarof with the animal facility in DRF, have a good base of scientists, and started our PhD program with the Manipal University. There are many other things that I was fortunate to be able to do at LVP in different areas. This is one such example that we started Innovation Center along with the MIT Media Lab and BITS Pilani in 2013, and that resulted in the inauguration of the Innovation Center at LVP by President Kalam. And today that center has an incubation center for eye healthcare startups. And many of those innovations, like folding for opters, are commercially available and being applied in different walks of life. I think this was another project that we were able to do, bring the technology of Boston scleral lens manufacturing in India for the first time in LVP in 2017. And now the Boston scleral lens is available to everyone in Southeast Asia. President Sirleaf of Liberia, her son was our patient, and she visited, and as a result of that, we are able to start an eye center in Liberia to just help the needy people there. Similarly, Bill Kite, a friend and a mountain climber, and himself runs a school there in Leh and Ladakh. He visited, his patient we treated, and as a result, we started a secondary center in Leh and Ladakh. Fitness-wise, I think it's nothing more important than this, especially as we get older. The only insurance is by doing exercise and building your muscles. We started in LVP, these faculty, we used to be in the gym at 5 a.m. and be in the class by 6:45 a.m. And now I do regularly my running, the strength training and everything else. So my advice to the young investigators or researchers who want to be a scientist as well, be action-oriented, do more surgeries, see more patients. Learn to deal with your fear of failure and fear of criticism. Understand your strengths and weaknesses. And especially if you are in leadership position, build a complementary teams. Don't be self-critical always. Believe in yourself and be nice to yourself. Collaborate. I think sharing the work, intellectual as well as other work, is the only mantra that will get you far. Thank you very much.
Thank you, sir. And now, as is customary from the panel of our experts, we will have a word of wisdom first from Dr. G.N. Rao sir, then from Dr. Harbansh Lal sir.
Thank you, Partha. That was a wonderful session, and I have very little to say, but I think all that I want to say is Indian ophthalmology has an opportunity, a wide opening to dominate the world, if only we want to do it. If only we want to do it is a big condition. There is enough competence in the country. There are enough islands of excellence in the country. And there are enough opportunities with the magnitude of problems that we see. There are also challenges for which we can find answers. Our country has the largest magnitude of blindness problem and vision impairment. And our country also has found many solutions to deal with these problems. But yet, there is a lot of unfinished business. And in attending to that unfinished business are opportunities for individuals, institutions, and our country as a whole to become the number one in eye care in the world. But again, with the condition, only if we want to become one and only if we want to work for it. If we don't put in our work, we'll lose that opportunity. And I have a nagging feeling that we are losing that time very rapidly. That will not remain open for us for too long. The other countries in the world who can easily capture that opportunity and exploit that. So to all the youngsters and ophthalmologists of the future generation, my appeal is, go for it. You as individuals can be the best in the world, and together you can make Indian ophthalmology the best in the world. Let's all strive for it and get it done. Thank you.
Thank you very much, sir.
Thank you, sir. And after sir has spoken, I think I don't have to say much, but I salute to all the stalwarts on whose name this endowment lecture has been started. They have done a great service to our country and made us proud. And I congratulate all the recipients of this award. They have the torchbearer of our ophthalmology in the world and in the country. And I'm sure, sir, your vision, your dream, the way you have led us from the front, I'm sure there'll be many youngsters and we will not lose the opportunity and we'll take it forward. Thank you for being here, sir.
Thank you very much, sir. Thank you for being with us here today. And it's really a great honor for us, sir. Thank you very much. The session stands closed now, and we prepare for the next session.